So, with your permission, can we start with the presentation?
Yes, sir. It's your masterclass. Please go ahead.
Just a second. Hmm. As uh, as Varun, we were discussing just yesterday that of the many patients that I have been seeing from various countries, a common problem that I have noticed is in fact the presentation of the patients, which is in advanced stages of cancer, which is late, which restricts our ability to offer them curative options many times. So that is why we thought of this session wherein we discuss with our friends of when to suspect cancer and how to refer the patients timely. So, if I were to briefly touch upon the role of the healthcare providers, they can primarily help identifying cancer early by knowing the symptoms. There is no other better hack to beating cancers than an early diagnosis, which directly is related to an improved survival of patients. The second most important thing that our primary healthcare physicians support us with are the timely follow ups on unusual or persistent symptoms and abnormal lab findings. So somebody very nicely put it in front of me that one should actually think of cancer whenever there are persistent symptoms, whenever there are progressive symptoms, or there are peculiar symptoms. So that is where the timely follow up done by our healthcare providers is so very essential. The third major area where they can help us is the stress on the need for screening for common cancers that are prevalent in their society. Mostly in Africa, that I see men get diagnosed with prostate cancers, women come with a lot of breast cancer issues, and these are some common cancers which we can definitely identify early and have a major impact on survival. Next, ensuring compliance during the cancer treatment and regular follow ups is also something that our partners in health can help us with. Spreading cancer awareness and debunking myths is definitely a part of each one of ours responsibility in managing patients with cancer. So, if I can touch on these seven brief warning signs of cancer, I would say any gradually increasing swelling or lump in the breast or elsewhere, which may not be associated with pain, persistent, unexplained wart or sore in the mouth or elsewhere, with changes in appearance of the skin and which are not healing or are worsening with time. Patients complaining with persistent hoarseness or nagging cough, especially if it's associated with a blood streaked sputum or the patient has a history of tobacco abuse. Patients complaining of persistent bloating or abdominal symptoms, which may be associated with jaundice. Patients having any unscheduled or unexplained bleeding or persistent discharge from anywhere in the body.
It's not YouTube.
Pa- Patients complaining of a recent onset change in the dietary patterns or bowel and bladder habits or breathing difficulties. And last but not the least, any recent onset persistent pain or recurrent infections or functional deterioration of the patient which is otherwise not explainable. These are some warning symptoms that as clinicians we should be wary of. We should think of cancer whenever we come across these symptoms in our patients. So, to start our discussion, I would start with something which we see very often, very commonly, which is a breast lump. Now, many of us in our clinical practice come across patients who come forward with breast lumps. Sometimes these lumps may be painful, sometimes these may be painless. But it is very important to take a good medical history of these patients, to examine these patients. In our medical jargon, we call this a triple assessment, wherein we subject the patient to a clinical examination and we advise appropriate radiological and pathological tests, which could be a mammography, ultrasound, MRI, depending on the availability of resources and the clinical setting, and at times pathology, which could be a biopsy or an FNAC. These tests, in congruency with each other, are able to give us a specificity of understanding why the problem is happening and what is to be expected in the course of the patient's natural history of disease. The warning signs that should alert a clinician should be any changes that are seen on the breast skin. If the patient is more than 30 years of age and has an unexplained lump in the breast or armpit, and any patient more than 50 years with one-sided symptoms, which could be nipple discharge or nipple retraction. There are definitely advances in the breast surgery that we have in our country. We are able to offer breast conservation surgery to our patients. We are able to offer good cosmetic outcomes with the use of surgical techniques such as oncoplasty or whole breast reconstruction. Not just that, we also offer our patients sentinel lymph node biopsy, lymphovenous anastomosis, and reverse axillary mapping. On the left, we can see a sentinel node specimen being examined to assess the activity in the nodes, which is where we are seeing that with the probe, we are able to assess the high Muller counter, which tells us that there is in fact a sentinel node in the specimen. Not just that, patients who are undergoing prophylactic or preventive mastectomies or mastectomies for something which is really early as a cancer, we can offer our patients robotic mastectomy and immediate breast reconstruction as well. It is also important to stress upon the screening strategy for these common cancers. So, digital mammography or digital breast tomosynthesis is strongly recommended for women of the age of 50 to 74 years every 1 to 2 years. Not just that, even clinical breast examination, if done properly every 2 years, along with breast cancer awareness, does definitely have an impact in saving lives lost due to breast cancer, as has been proven in clinical trials done across India. In specific situations, breast MRI may be recommended for women who have a strong family history or certain genetic mutations. In younger women, breast ultrasound or breast sonography yields better results than an X ray of the breast or the mammography. These are some tips that I would suggest our clinicians to advise patients when they are going for mammography, which would be avoiding mammography the week before a patient is due or during her menstrual cycles, because the breast would be swollen and tender at this point of time. We must advise patients to avoid wearing deodorants, powder, or perfume on the day of mammography, as these can show up as artifacts. Our patients should be wearing a top with skirt or pants instead of a dress so that it is easier for them to undress from the waist up. And the patients should be advised, if there is any recent vaccination, to wait for 4 to 6 weeks before scheduling a mammogram. Next common symptom that I would like to talk about would be hoarseness. Now, many patients present with complaints of a persistent, unexplained change in voice. We should be on our guards when the patients have a history of tobacco abuse, they are more than 45 years of age, there is any associated recent loosening of teeth, there is any unexplained lump in the neck, unexplained ulceration in the oral cavity, if there is any lump in the lip or the oral cavity, or any red or white patches that are seen in the mouth. Now, hoarseness of voice could be because of multiple reasons. It is not just the cancers of the throat that can cause the hoarseness of voice, but because of the course of the recurrent laryngeal nerve in the chest. It could be perhaps due to lung cancers or esophageal cancers, which would be advanced in nature, that there can be a hoarseness of voice as well. So that is why it is classically said in cancer that the symptoms are difficult to understand and they can mask one disease or the other very easily. And that is why an opinion of a surgical oncologist is so very important. And if we are to we are to talk of how we are able to rehabilitate our patients. Now, this is the voice quality that we are able to give our patients after a laryngectomy, which is basically surgery of the voice box. Uh, So, as we were hearing, this gentleman is from Ethiopia and had a salvage surgery, which was basically that he had already undergone radiation therapy for the cancers of the larynx that he was suffering from, but there was residual cancer despite that, and we had to surgically remove the voice box of the patient. We were able to give him a prosthesis which enabled him to speak despite the surgery. Another method of rehabilitating our patients who lose their voice because of the surgery is the use of electrolarynx. The voice in such cases is slightly more mechanical, as we can hear in the example here. Just a second.
So we are not able to hear the audio from the video that you are playing.
Oh, I'm so sorry. Um, is the audio audible now? Was the audio heard now?
No, sir.
Oh, I'm so sorry that the audio is not audible. I'll anyhow move to the next slide.
Okay, sir.
So, screening strategy, as I discussed for breast cancer, screening is something which is very important. It can help us in identifying cancers timely, which gives us more options to uh, treat the patient, and also it gives a better survival, better outcome to our patients. So, patients who are at high risk of developing any cancers of the mouth should routinely, at regular intervals, maybe a month or 2 months, inspect and examine their mouth, various areas of their mouth themselves, so as to identify any new ulcer or any new patch developing that can be brought to medical attention timely. Next, I would like to speak on cough. Now, many patients complain of cough that is persistent, that may be associated with unexplained hemopsis, which is basically staining of the sputum. Patients who are more than 40 years of age, who have associated history of tobacco, who may be having an abnormal finding on chest x-ray, or have an associated history of asbestos exposure, the clinicians should definitely think of lung cancer as a possibility. The screening strategy for these cancers could be use of an annual low dose CT scan of the chest, which is basically indicated for heavy smokers. It is called low dose because the radiation dose is very less and it can be safely used as a screening modality for our patients without causing them any harm. The radiation dose is roughly 1/10 of what would otherwise be the exposure dose of an individual from a CCT of the abdomen. It is generally indicated for heavy smokers, patients who are 50 to 80 years of age and otherwise good health, and smoke more than 20 pack years of cigarettes. If detected timely, we can offer these patients with surgeries also. On my right, I am showing a video of a robotic lobectomy that was performed for patients suffering from cancer. So, in the video, you can identify how the lung is affected with cancer and how we are using the robotic technology to remove the affected part of the lung with a minimal surgery. The patients recover from such a surgery very quickly and they are able to resume their normal activities. It is indicated for various cancers of the lung that I see commonly. Next common symptom that I would like to talk on would be bloating and abdominal distension. Patients, especially women, may present with a feeling of generalized distension of the abdomen. At times, they may have ascites or free fluid in the abdomen. They may also be having a nodular or fixed mass that can be felt on examination by the clinician. So, in case these patients are more than 50 years of age, associated with pelvic or abdominal pain, vague symptoms like increased urinary urgency or frequency, unexplained weight loss, we should definitely be getting an ultrasound of the abdomen and a CA125 checked for these patients in order to rule out any malignancy. Many times we see patients with widespread disease in the abdomen. These are images of some of the cases that I have operated in the past, wherein there is a jelly like material in the abdomen which is filling it and causing the bloating sensation. These are called jelly belly or pseudomyxoma peritoni, and they respond very well to cytoreductive surgery along with HIPEC. HIPEC is a chemotherapy session that is given intraoperatively. The chemotherapy is at a higher temperature, because of which the penetration is seen to be better and the cure rates for our patients are much better. I would like to point out that a lot of these patients were previously thought to be inoperable, untreatable. But now, because of the advances and the infrastructure that we have in our country, we are able to offer cure to these patients with the modalities that we have to offer. Next common symptom would be any unscheduled vaginal bleeding. So, it is called a postmenopausal bleeding when it occurs in women aged more than 55 years or who have already undergone menopause. If it is associated with vaginal discharge, hematuria, or anemia, it is definitely a symptom for concern. It needs to be evaluated for any endometrial cancer. Not just that, cervical cancers are also very common in African countries, which can be very easily prevented by a timely administration of the human papillomavirus vaccine. It has been noted that girls between the age of 9 to 14 years, if they are vaccinated with two doses of such a vaccine, or girls between the ages of 15 to 26 are administered three doses, they can significantly improve and avoid any vaccine, any cervical cancer related, HPV related cancers. The screening strategy for these cancers would be a pap smear or an HPV test, which is primarily ordered between 25 to 65 years of age for our patients. These patients may also get an HPV DNA co-testing done, which is advised every 3 to 5 years for our patients. The screening strategy for these patients could be a transvaginal or an endovaginal ultrasound or an abnormal, which may detect an abnormal endometrial thickness. Women with abnormal vaginal bleeding or with a history suggestive of familial cancers should start early with these modalities. We should not schedule the test for our patients who are having period or if they have had any intercourse in the previous 2 days. The next common symptom that we see in our patients could be any change in dietary or bowel habits or rectal bleeding. Warning symptoms for our patients would be dysphagia, hematemesis or melena, upper abdominal masses, acute involuntary weight loss, anemia, which could be associated with upper abdominal pain, persistent reflux, symptoms which are not relieving with medication and acids, and if any upper abdominal symptoms are associated with jaundice. The next common thing could be any alarming features which are present, which are coming in the age group more than 40 years. There could be persistent bleeding after successful local treatment of hemorrhoids. These patients could be having concomitant changes in bowel habits, constipation, or diarrhea. Patients with progressive abdominal pain or unexplained weight loss, abdominal masses, anemia, which may require blood transfusion, or significant family history are also something which is important. These patients can be screened with colonoscopy, which should be recommended starting from the age of 45 years and up to 75 years, or till the life expectancy is more than 10 years. Patients can be offered colonoscopy if they're high risk individuals earlier than 45 years, or the screening can be reduced to every 1 to 3 years. Patients who are not willing for colonoscopy can be offered stool based tests or visual exams like flexible sigmoidoscopy. So, I would like to end our presentation by just reiterating the fact that all breast lumps must undergo triple assessment. Hoarseness lasting for more than 2 weeks, especially in the absence of acute infections, with patients with history of tobacco or alcohol abuse, should definitely be evaluated. Any smoker who's more than 40 years of age with unexplained hemoptysis or abnormal findings on chest X-ray must definitely be evaluated. Patients with fixed or nodular pelvic masses with elevated CA125 or in the presence of ascites should not be ignored. Unscheduled or unexplained vaginal bleeding or changes in dietary or bowel habits associated with weight loss or anemia should definitely be evaluated. I'd also like to say that surgical oncologists are the best doctors to assess patients suspected for cancer because surgery is an integral part of the curative treatment strategy. Cancer diagnosis and treatment can span multiple organ systems and modalities. Thus, a surgical oncologist who's a jack of all trades is the best bet. We are better equipped to navigate multidisciplinary care for our patients. We are updated with the oncosurgical principles and rehabilitative or reconstructive options to deliver better outcomes. And we can, in fact, predict the needs of our patients based on the volume of patients that we see and treat. I'd be happy to answer any questions if there are from the audience.
Yeah, thank you, Dr. Shubham. And so now we are waiting for questions from others. Please feel free to ask your questions. February is the cancer month, and the reason for organizing this masterclass is to help you away. Dr. Shubham, I have one question. Like when you were giving the presentation, so typically, how do a doctor practicing in resource constraint? Many times, the problems that our colleagues in Africa face is that not enough diagnostic facilities or not enough resources available to to properly screen large populations. So how should they handle this dilemma? No, where I'm coming from, let me be more specific. Where I'm coming from is that limited resources and making them available large population and so in what kind of triggers should they be absolutely sure where diagnostic facilities are limited that that this should be done or this could be false alarm, like if there is a way to determine that.
So any cancer, because it requires a lot of resources of investigation of treatment, should definitely be evaluated at a good high volume center that gives the best chances of cure to our patients. It is very difficult to assess at a initial stage of what would be the patient's outcome, what would be the patient's treatment. So we need to primarily rely on the clinical signs and symptoms that I have discussed many times, that we are able to suggest that patient to be evaluated at a high volume center.
Okay. So, sir, basically, what I understand is that, as you said, the classic, those 7 areas and those persistent symptoms. So that is suspicion, and then the patient should be evaluated with proper investigations. So now, sometimes what we do is, for our Jivo doctor network, like working with the specialists in India, we try to create those guidelines, protocol that if this is what is suspected, and so you get these kind of investigations for your patient. So based on your presentation and your experience as a surgical oncologist, probably we can prepare certain such handbook or guideline for the doctors so that they are equipped when they, okay, let's say in any you discuss in case of breast cancer, if there is lumpiness or whatever, these system persist, you had recommended that they have to go through those radio scans, MRI, etc. Plus plus that oncopathology tests, biopsy, etc. So
Yes.
similarly, some simple protocols. I know a lot of medical literature exists, but it is very difficult for doctors to follow. But something that you follow here, like your presentation laid out, we will share your presentation with them. But perhaps we
Definitely.
can work out a checklist or a protocol that this happens. Please, if possible, get these tests done to rule out or to confirm the suspicion.
So, at a very basic level, I would suggest that any complaints of the breast should definitely be evaluated with a mammography or an ultrasound at the least, and if possible, a biopsy or an FNAC, which is basically the triple assessment that I was talking of. Next, I would say any cancer that we are suspecting in the abdomen, the least we need to do is an ultrasound of the abdomen. That can guide us to which other imaging modality would be better. I've traveled a lot to various African countries, so I know that basic radiological investigations are available. So maybe a CT scan can guide us better. It is actually at times very difficult for us also to comment on what the treatment outcomes could be for the patients. Like last week only, I saw a patient with a huge abdominal mass. The patient was very emaciated and had come from Tanzania. The doctors over there were suspecting a lymphoma in the patient. A biopsy had not been done because the patient was very emaciated. When we saw the patient over here and we examined, there was generalized lymphadenopathy that the patient was having. So clinically, it was going along the lines of lymphoma. But to our surprise, when we did a biopsy from one of the lymph nodes, it came as a neuroendocrine carcinoma. Now that flipped the clinical diagnosis on its head and opened a lot of treatment options for the patient. So that is why it is very difficult based on clinical history and findings alone. But the basic workup remains the same for majority of patients, which would be one imaging modality that addresses the area of concern and a biopsy if it is feasible. It is also important to understand that biopsy is a very nuanced test. So, at one end, where we may not need a a pathological confirmation for liver cancers or kidney cancers, at times, the other extreme is wherein a biopsy may be more damaging to the patient if not planned or done properly. So, that is why I wouldn't stress on the need of a biopsy from the primary healthcare physician. I would suggest let that be the decision of the treating oncologist of how and where to get the biopsy from.
Dr. Ornana Paul, please go ahead, ask your question, sir. Okay, so we have a question from Dr. Stephen Kope. He is from Cameroon. He is a general surgeon. And first, he thanks you for this great presentation, sir. So he wants you to share, can you tell something about malignant wound?
So, malignant wounds anywhere is something that needs to be confirmed on a biopsy of what exactly is the reason for that wound. I would not expect that to heal on its own, but it is also important to understand how we can deal with it surgically or otherwise, depending on the patient's condition. It should be subjected to a biopsy to confirm the nature of malignancy, to confirm what are the treatment options. There should be appropriate imaging that is to be done to understand the underlying structures that are involved. And then it is best to offer surgery if it is resectable to these ulcers.
Dr. Shubham, we have a question from Dr. Onana Paul. In fact, it is a patient case notes that he wants to discuss. So he has this patient who had laryngeal cancer and he had
Okay.
surgery done and the voice box was affected. Now he wants an aid to help him use his voice, but does not want an invasive surgery. Are there any options available for him?
Yes, definitely. So the option of the electrolarynx that I was showing, unfortunately, the audio could not be heard, is an external prosthesis. How it helps is basically once the device is attached to the skin, it creates a lot of vibrations at a high speed, and the patient can in fact vocalize. If we agree, I can share the video of the electrolarynx being used on the WhatsApp group that we had created, and you can then probably share it with
Sure,
our
sir.
friends.
Yeah, we will do it, sir. So if you
Yeah.
can share it, sir, we will share it across to all the participants. And Dr. Paul, I suggest that now you are familiar with the process, like on the work group, you can share more details about the patient. We'll document the case file and share it to Dr. Shubham. Then he will be able to advise more specifically what can be done for this patient.
Yeah.
Shubham, I mean, there is a question that I wanted to ask since I saw that slide. So on your slide for the smokers, it was written that 20 packs. So 20
Hmm.
packs, like lifetime, someone who has smoked 20 packs is at a risk? 20 packs of cigarettes?
So, 20 pack years basically means The number of packs of cigarette that anybody smokes in a year multiplied the number of years one has been smoking. So if let's say somebody is a heavy smoker and smokes 20 packs per day,
No, it's not
and
possible. 20 packs per day is 220 into 20, 400 cigarettes. Not possible.
so there are heavy smokers that we see. So not 20 packs per day, sorry, 2 packs per day for 10 years.
Okay, so 40 cigarettes per day. Okay,
Yeah, so 2 packs per day for 10 years makes it 20 pack years, or 1 pack of cigarette a day for 20 years makes it 20 pack years. Or
okay.
somebody who's been smoking just half a pack of cigarette a day but has been smoking for 40
Mm.
years, that makes it
Mm.
20 pack.
I think Dr. Samuel, yeah, Dr. Samuel, yeah, please ask a question. Dr. Samuel,
Varun have shared the electrolarynx on the group.
I will share, sir, with all the participants. After this, we will get the attendance and we'll share with all the participants. So, Dr. Rondona has asked what are the latest screening tests that are available for the different cancers that we can use for detection early. Dr. Rondona, what we will do is sometime like tomorrow or day after tomorrow, along with the participant certificate, we'll share the copy of Dr. Shubham Jain's presentation. Dr. Shubham Jain has shared it with us. So it is mentioned the tests suggested. Uh, Second, what we will do some homework and perhaps prepare some checklist, sort of protocol guidelines, practical guidelines that you can refer in what cases, what test to recommend. And I think Dr. Shubham mentioned like the CT scans or the ultrasounds is something that should be done. But Dr. Shubham, if you address this question, that will be great.
Can you repeat the question for me,
So,
Varun?
what are the latest screening tests that are available for different cancers that we can use for detection early?
So the latest screening tests, I would say the tumor markers are something that can be used. Uh, it is very important to understand the patient's history before advising these tests. We need to understand the patient's age, the patient's family history, the patient's smoking status, based on which these tests are recommended. So, at a very basic level, we can be recommending the radiological tests. So, for example, a mammography for a lady, an ultrasound whole abdomen for a lady being evaluated for endometrial or ovarian cancer. For men suffering from prostate cancer, a blood test, which is a serum PSA, can be advised. Uh, for smokers, we can do a CT scan of the chest. And the frequency with which these need to be done also vary a lot. So somebody being suspected for colon cancer can either get a colonoscopy done every 10 years or a sigmoidoscopy along with a fecal occult blood test. These can identify majority of cancers early.
Okay. So there's a question from Dr. Okay, yeah, Dr. Emmanuel, we will make the recording of this class available to you. We'll upload it on YouTube and share the link. Now, there's a question from Dr. Ivan. Dr. Ivan is from Uganda. So he said, like, most often biopsy is the best way to detect cancers, but most times it takes a long time. So, are there any better options or alternative to that, which are faster?
So, Dr. Ivan, thank you for that question. I understand your concern with the time it takes for the biopsy results to come. In our country as well, because India is a vast country, I've been across various centers. We do face such similar issues in our northeastern part of our country, wherein the results take a lot of time. The processing time for the biopsies are high. Uh, a couple of ways that our colleagues have circumvented the problem is one, they have started now relying more and more on FNAC. Now, though that is not recommended, it is not the best treatment strategy. But for situations where it is difficult for patients to stay for prolonged periods of time at a particular place because just because the diagnosis is not being made, in certain select situations, we can make treatment decisions based on an FNAC. The second way out is the use of frozen section facility. Now, frozen section does give us some amount of confirmation very quickly, but again, it is a very resource intensive setup. which is usually available in high volume centers dealing with cancer patients very routinely. Short of that, I would simply suggest that if there is a suspicion of cancer, it is best to refer to an oncologist who would be able to guide if a biopsy is needed, where should the biopsy be taken from for the best results for our patients.
So we have a question from Dr. Alam. Dr. Alam is from Ethiopia. So do you recommend BCS for small breast ductal carcinoma of the left breast?
Definitely, Dr. Alam. So, breast conservation surgery is one of the advanced techniques of treating breast cancers that we are able to offer our patients suffering from early breast cancer. We routinely discuss it as a possibility with our patients. The breast conservation surgery offers a definite cosmetic advantage to our patients, but uh, note of caution here is that it also needs to be definitely followed up with radiotherapy. There are very strict criteria seen on imaging patients' family history that need to be taken into account before offering breast conservation surgery to the patients. Not just the breast conservation surgery, but we now combine it with oncoplasty, which is basically how we close the scars so that our outcomes of cosmesis for our patients are acceptable and superior to other non-cosmetic or non-oncoplasty breast conservation surgery scars. So it is definitely something which must be discussed with the patient suffering from breast cancer. And if it is feasible, it should definitely be offered to our patients.
We have some information, further information shared by Dr. Onana Paul. He had introduced a patient to Jivo, and we had a virtual interaction with the surgical oncologist. But the options that were given, like as he said, the patient is averse to invasive procedures, so the patient was not comfortable. So if you want, if we can have the video you talked about, yes, Dr. Shubham has shared the video with us. Dr. Paul, I'll share it with you and share it with the patient. Then, if the patient wants to discuss further, we can always request Dr. Shubham's availability for a virtual consultation for you, with you and your patient. Dr. Shubham is talking about that aid in voice box case.
Okay.
Okay.
So I think Dr. Orona Paul also mentions about a breast cancer patient with
Yes, yes,
stage.
I'm coming to that. Yes, sir. This is the question. So, a breast cancer patient, stage
Huh?
three,
Huh?
she has had five chemos.
Hmm.
What test can we do to check the state of treatment progress?
So patients who are given chemotherapies as a neoadjuvant because they're locally advanced usually have a clinical improvement where the patient themselves notice a reduction in size of the breast lump or improvement in the skin findings, whatever the patient was having. Short of that, or in addition to that, what we can also do is we can repeat the imaging either with an ultrasound or with a CT scan, whichever was done prior to starting the chemotherapy, to objectively confirm the response that the patient is having. Obviously, surgery is an integral part of the patient's treatment. Without offering surgery to these patients, the treatment is simply palliative. So it is very important that this patient be assessed by a surgeon who can now offer surgery.
Okay. So, another question from Dr. Arunana is, what is your take on mebendazole and ivermectin as adjunct tablets for cancer treatment?
So mebendazole and ivermectin, Dr. Orana, is being evaluated for adjuvant therapy for cancers, but there is still not sufficient scientific data backing them as something that can be relied upon. We are still primarily relying on the standard chemotherapy. What in fact is showing results are the use of targeted therapy now and immunotherapy across various cancers, and that is something which is very exciting. The experience that we have with our patients are very encouraging. The cancer survivals have improved, the recurrences have reduced significantly, the side effects are less. As of now, the price definitely is a sore point. The price, these are costly medicines, but now with the generic medicines also coming, and the patient assistance programs being extended to international patients as well, these costs are drastically coming down. And we hope to offer more and more advanced treatment through immunotherapy to our patients, even from Africa.
So there is a follow-up question from Dr. Alim from Ethiopia. How do you see complications from radiotherapy on the left side of the chest?
So many of my patients have radiotherapy for left-sided breast cancers or tumors that affect the left-sided chest wall. The most common complication is the cardiotoxicity. The way our radiation oncologists manage it are with a deep inspiratory breath hold and gating techniques of radiotherapy. The way they do it is they train the patient of how to hold the breath during the active phase of radiotherapy administration, so that the toxicity to the heart is reduced to the least. Also, the motion of the chest wall is reduced, and the radiation can be delivered to the accurate target volume that is decided by the radiation oncologists. So that are the two most important ways that I see that the toxicity is being reduced. Obviously, the use of more and more precise machines, the IGRT therapy, the 4D CRT, these are having more and more precision for treating the left-sided tumors of the breast and the chest wall.
Dr. Shuma, we have a follow-up question from Dr. Ivan. So his question is, what are the myths in assessing suspected cancer patients?
So a lot of myths that we hear in our country as well, Dr. Ivan. The most important one is the hesitancy of our patients to get the biopsy done. Many of them fear that the biopsy would actually cause the cancer to spread. What I would, through this conversation of ours, like to say is that the biopsy is probably one of the most crucial, important tests that any cancer patient needs to have. Uh, if planned correctly, if performed correctly, it will not lead to any spread of cancer. But as I said, it is a very nuanced test, and it is the decision for performing the biopsy is best taken by an oncologist. Many patients, apart from this, also have uh, some beliefs of cancer occurring because of certain dietary habits or certain things that they do. Of that, I would just like to say is that gone are the times where we used to actually say that cancer occurring in patients is primarily the patient's fault, himself or herself. Uh, Till not very long ago, we used to believe that all cancers happen because of some indulgence, some tobacco abuse, alcohol abuse. But now we see more and more cases of cancer happening not because of the patient's fault, not because of their indulgences, but they could also be because of the environment around us. They could be because of our genetics. So that is another myth I would like to bust, wherein patients are usually not at fault if they are diagnosed with cancer. It is very important to destigmatize the patients suffering from cancer, because that is actually what keeps them away from taking treatment in time.
So we have a question, another question from Dr. Alim. So how do we approach cancer of unknown primary with only liver mets, oligomets?
Very important question, Dr. Alaman. Thank you for that. So, this is in fact a very tricky situation where we see metastatic deposits in an organ and are not able to identify where it is coming from. A very important way of understanding and addressing these problems is A, we get a PET CT imaging to be sure that there is no other site of disease elsewhere in the body. B, we ask our pathology colleagues to perform immunohistochemistry tests on the biopsy and to give us any clues of where these cancers could be arising from. Based on the results from our pathology colleagues, we then do directed and targeted imaging. If it is an upper GI tract origin, we perform endoscopies. If it is something which is arising from the genitourinary tract, we do detailed imaging, we do hysteroscopies, etc. and we try to assess the primary as well. Many times we are not able to find the primary, but the case, for example, that you have quoted, if there are only liver mets, we would start our treatment with chemotherapy. The treatment starts definitely with the palliative intent for these patients. And depending on how the patients are responding to treatment, we may decide if the patient is benefiting really very well and his or her general condition has improved. We may try to offer a curative approach treatment to them, which may involve a surgery also, depending on the patient's condition, depending on the patient's performance status, how the disease is responding, and obviously if the patient understands that this can be attempted, but nothing can be assured to the patient.
So we have a couple of more questions from Dr. Ornana Paul. So one is, what is your take on the use of terahertz radiation therapy as an adjunct for cancer management?
So, this terminology, Dr. Arona, unfortunately, is something which is new to me. I am sure there would be synonyms to it, terahertz radiation therapy. Would it be a proton therapy that you're talking about or something else? I'm not sure.
Dr. Paul, can you clarify?
We can answer his other question in the meantime.
Yes, sir. So which of the cancers do you have patient assistance programs for, and how does it work? Which patients are eligible for?
So, Dr. Ornona, till very recently, it was only for the Indian patients that you were having patient assistance programs for the targeted and immunotherapies. This basically means that because these drugs are very costly, uh, the companies come forward and assistance in procuring these medicines. They may cost up to half or one third, a fraction of the cost that they would have otherwise costed, which makes it more and more affordable to the patients. Not just to the African, it is many times out of reach for our domestic Indian patients as well. Unfortunately, because of the regulations, the laws around surrounding medical treatment, we were not able to extend these programs, the benefit of these programs to patients who are traveling from abroad. But now, more and more commonly, the laws surrounding these are relaxing, and we are able to offer benefit to international patients as well.
Dr. Shubham, Dr. Orna has clarified that terahertz is an electromagnetic spectrum, and I was also doing researching this AI LLM. They have made various options that photonic interaction rather than
I'm
ionized
sorry,
radiation.
I wouldn't have any idea on that, Dr. Nona.
Dr. Nona will ask a medical oncologist or radiologist and get
Probably a
back.
radiation oncologist would be better.
Yeah, yeah. Okay, Dr. Arona, as Dr. Shubham said, that this is not his area, and he will, I mean, we will ask a radiation oncologist and get back to you on this clarification. No other questions, then I think we can wrap the class, Dr. Shubham.
Okay.
And if you have any other follow-up questions, you can write them on your work group, and we will direct it to Dr. Shubham. And Dr. Ornana, I will just share the video of that voice box assistance. You can share it with the patient, and if needed, we can share the case with Dr. Shubham and organize if the patient wants to move ahead, organize a consultation, pre-travel consultation
Definitely.
if
I'd be
needed.
happy to help.
Okay. Thank you, Dr. Shubham. Thanks a lot for this session and for helping, the detection strategies, detection strategies, and the management protocols. Thank you, sir. Thanks a lot.
Thank you, Arun. Thank you so much, Jivo team.